GS residency training in Chinese General Hospital and Medical Center, and had her fellowship training in St. Luke's Medical Center in surgical oncology, and clinical observership in oncology at ECSF Helen Diller Family Comprehensive Cancer Center at Mount Zion. He's an active consultant at Chinese General Hospital and Medical Center, Asian Hospital and Medical Center, Hospital ng Muntinlupa, and she is an assistant training officer at the Asian Hospital and Medical Center. She's also a surgical oncologist. May I now call on Dr. Kathleen S. Chua to begin her lecture.
Thank you, Dr. Claveria, for that introduction. I'll be flashing my pre-recorded video. And just in case the residents will have any questions, you may type your question on the chat box and I'll answer it after the video, okay?
Okay. Noted po.
How do you stay pretty?
What's your skincare routine?
Good day, everyone. This is Dr. Kathleen Chua. Thank you to PSGS for inviting me to be a lecturer for this year's CERES review. I hope that this lecture can help all of you for your exam. Just a few reminders before we start. So this lecture is formatted specifically as a study material for the exams. It is designed to be concise, high yield, and easy to remember. Hence, this is not a complete representation of everything you have to know about this topic. And I emphasize that the way you study for your own patients should be individualized. The source for this review is from Schwartz and NCCN only for uniformity and simplicity. Some of the cases are taken from actual journal reports. Based on the CERES 2024 guidelines, the allocated number of questions that will be given under this topic will be 12 questions for the juniors and seniors and 9 questions for the intermediate residents. I will be dividing my review into 2 parts. The first part will be about non-cancer lesions, and the next part will be about cancer lesions. Also, I will be excluding some topics under the skin chapter that will be discussed by other lecturers. A 40-year-old female overweight smoker came in due to recurrent painful mass at the axilla. 2 years ago, she reported to have similar lesions on her inframammary folds and groin, which were treated with unrecalled antibiotics alone. However, the one at the axilla keeps on recurring and has recently worsened, noted by the appearance of sinus tract and scarring, but still with areas of healthy skin separating the areas with involvement. What is the management for this patient? The first case is a case of hidradenitis suppurativa. To the left side of the screen, I've already highlighted in yellow text some of the keywords that to look out for when you are encountering cases like this. So, to be able to answer the question regarding the management for this patient, you have to know the 3 stages of hidradenitis suppurativa, known as the Hurley classification. So for Hurley stage 1, these are characterized by single or multiple nodules without sinus tract. These are primarily managed by hygiene plus oral or topical antibiotics such as clindamycin. For stage 2 Hurley classification, such as what is found in our patient, these are characterized with lesions with sinus tract and scarring. The management will involve antibiotics, TNF-alpha inhibitors such as infliximab, followed by excision. And for more advanced stages, the stage 3, which is characterized by diffuse disease with interconnected tracts. So if it has interconnected tracts, it doesn't have the areas of healthy skin separating the areas with involvement. So for stage 3, the main management is the use of antibiotics followed by wide excision with skin graft. For the second case, this is a 51-year-old woman who comes in for consult for multiple right leg ulcers with violaceous margins, which initially started as a single lesion that progressively worsened. Tests were done to exclude any possible associated systemic diseases and inflammatory disorders, which revealed modest increase of inflammatory parameters. Skin biopsy of the ulcer margins revealed a diffuse infiltrate of inflammatory perivascular mono and polynuclear cells in the absence of any infection. Wound GSCS came back negative, so it's a ulcer with negative culture. Take note of that. Appropriate treatment consists of This is a case of pyoderma gangrenosum. The keywords to look out for are the presence of the so-called sterile pustules and the presence of inflammatory cells despite not having a bacterial infection. So the questions will often emphasize that the lesion is culture negative and that the patient will undergo some tests that will rule out inflammatory disorders such as IBD, rheumatoid arthritis, Crohn's and hematologic or immunologic malignancies such as ITP or lupus. The most common site will be the legs, and the treatment will involve identifying the underlying disorder and treat it. So do not answer excision alone. The treatment is always systemic. For the third case, this is a case of a 9-year-old boy who is a known case of epilepsy being treated with anticonvulsants, but had a recent addition to the meds to control the seizure in the form of carbamazepine. 2 days later, the child presented with rash, with conjunctivitis, cheilitis, and persistent fever. On admission, he had decreased O2 saturation, and he was also febrile. Skin examination found flaccid bulla, multiple skin erosions of the lips and in the genital area, which extended to 8% of the body surface area. The Nikolsky sign was positive. On day 2, he presented with respiratory distress, hypotension, and inability to swallow. Hence, he was intubated, ventilated, and sedated. What is the next appropriate step? This is a case of epidermal necrolysis. It results in cutaneous destruction at the dermoepidermal junction. It results from cell-mediated cytotoxicity precipitated by initiation of a new drug, usually an anticonvulsant such as carbamazepine, but can also be precipitated by NSAIDs and antibiotics. It is characterized with the appearance of macular rash, beginning in the face and the trunk, and then to the extremities. It is also characterized by the pathognomonic Nikolsky sign, which is demonstrated when the lateral pressure is applied on the borders of an intact blister, resulting in a dislodgement of the normal epidermis and extension of the blister. So there are 2 types of epidermal necrolysis, and it will depend on how many body surface area percent the lesions will cover. For Stevens-Johnson syndrome, it is usually less than 10%, which is what we have in our patient, which is 8%. So this is indeed a case of Stevens-Johnson syndrome. The other type is called the toxic epidermal necrolysis, or TEN, which comprises more than 30% BSA. Anything in between or between 10 to 30% is called SJS-TEN. The most important management is to discontinue the offending drug or agent, and since SJS is life-threatening, if IV resuscitation and surgical debridement for local control are available in the choices, you can choose those also, on top of the discontinuation of the offending agent. Take note also that we did not include giving IV antibiotics simply because we are being more cautious in giving another new drug to the patient while suffering an SJS. A steroid is also controversial, so don't choose steroids. A 90-year-old female patient was noted to have a non-healing wound at the sacral area. She has been bedridden due to pneumonia for almost 3 weeks, and despite bed turning, the wound on her sacral area covered in black film persisted. What is the present stage of the pressure ulcer? Since the pressure ulcer was described to have a black film called an eschar, this pressure ulcer is considered unstageable until after undergoing a debridement to assess the viability of the structure's being. There are 5 stages of pressure ulcers. Stage 1 only involves non-blanching erythema over intact skin. Stage 2 has partial thickness injury with dystery or exposed dermis. Stage 3 involves full thickness injury extending down to, but not including the fascia. And stage 4 includes full thickness with destruction or necrosis of muscle, bone, tendon, or joint capsule. Pressure ulcers are usually caused by local tissue ischemia due to greater perfusion pressure of the microcirculation. The most common areas affected are those with bony prominences. Most common area is the ischial tuberosity, accounting to 28% of cases. Take note that it's not the sacrum which is the most common location. Also, the treatment involves the avoidance of prolonged pressure to at-risk areas or pressure offloading. Nutrition optimization, surgical debridement, and vacuum-assisted closure are also very important. Moving on to the next case, this is a case of a 57-year-old man presenting to the ER with fever, chills, and a wound on his left foot since 2 weeks ago after a vehicular accident. He had no previous history of vascular disease or diabetes. Despite receiving flucloxacillin, the wound was neglected and became necrotic with skin discoloration and a purulent, foul-smelling discharge. The leg developed functional impairment with severe claudication pain. All the digits were pale, cold, and numb. Pertinent blood tests showed WBC of 30 with predominant neutrophils with 10 bands. Serum chemistry also showed high lactate levels as a sign of hypoperfusion. FBS was also markedly elevated at 300, and the X-rays on the left lower extremity showed subcutaneous air. What is the appropriate management for this patient? So this is a case of a necrotizing soft tissue infection, or the NSTIs, for which a necrotizing fasciitis falls under. And for the management of these cases, it needs an immediate surgical debridement or amputation for source control. It's not antibiotic alone. And take note that when you bring this patient for surgical debridement, you need to return this patient to the OR for the next 24 to 48 hours to verify source control and the extent of the damage. So you need to re-debride this patient. So the 3 principles that form the foundation of the management of NSTIs is number 1, source control with wide surgical debridement. And the number 2 is broad spectrum IV antibiotics, especially if there's no culture yet. And the number 3 is supportive care and resuscitation. There is also what we call the laboratory risk indicator for necrotizing fasciitis, or the LRINEC. So basically what this does is that it tells us the probability that an infection is actually an NSTI. This helps us in doing decisions for our patient. So the components of the LRINEC is number 1, the CRP, in which you will add 4 points if you have value of more than or equal to 15 milligrams per deciliters. And then if you have a WBC count of more than 25, that gives you 2 points. A WBC count of 15 to 25 will give you 1 point. Hemoglobin values of less than 11 will give you 2 points, while a hemoglobin between 11 to 13.5 will give you 1 point. Low sodium or less than 135 will give you 2 points. Creatinine which is greater than 1.6 milligram per deciliter, will give you 2 points. And then glucose, more than 180 milligrams per deciliter will give you 1 point. So adding all the scores, if it gives you a score of 8 or greater, there is a high probability for NSTI. If the value is between 6 or 7, there's intermediate probability, and if it's less than 5, there's low probability of NSTI. Also take note that there are 3 types of NSTIs. The type 1 is the polymicrobial, which is the most common, wherein you will see basically a salad of infections: gram-positive cocci, gram-negative rods, and anaerobic bacteria, specifically Clostridium perfringens and C. septicum. This is why we initially give broad-spectrum antibiotics for polymicrobial NSTIs. The second type is the monomicrobial, in which we have to be wary of coverage for beta-hemolytic streptococcus and staphylococcus species, specifically with MRSA. So for these cases, we usually give cephalosporins coupled with MRSA coverage such as vancomycin. And also these NSTIs that fall under type 2 are commonly associated with history of trauma and toxic shock syndrome. Type 3 is fairly rare. It's from Vibrio vulnificus. Typically, patients who have type 3 will have history of skin trauma, and then they will expose their body to salt water. This slide shows a quick summary of uncomplicated versus complicated skin infections. So for the complicated, it's basically those skin infections that are limited to less than 75 centimeters surface area of the body. These include the impetigo, which is usually seen in faces of infants, noted as honey-colored crusting; erysipelas, which is infection involving the dermis upper layer; and then infection involving the dermis but deeper layer plus the subcutaneous is called cellulitis. Infection in the hair follicles is called folliculitis. And then if you have a follicle with swelling and collection of purulent material, that's called a furuncle. And a simple abscess that coalesced with multiple draining sinus tracts is called a carbuncle. For complicated lesions or skin infections, these are involving larger surface or more than 75 centimeters squared surface area, and they go deeper and beyond the dermis. So these again involves necrotizing fasciitis, and the immediate treatment is immediate surgical debridement and source control, supportive care, and resuscitation. The most common agent for skin and soft tissue infection is still Staph aureus. It comprises the most common agent in 44% of abscess formations. And if the patient is immunocompromised, these are often the agent seen. Pseudomonas, E. coli, Enterobacter, Klebsiella, and Serratia. This is another quick run-through of other notable skin lesions, specifically the warts. So we have the cutaneous and the mucosal warts. Specifically for cutaneous warts, we have the most common, the verruca vulgaris, or the common warts, involving HPV types 1, 2, and 4. When you have a plantar and palmar warts, these are HPV 1 and 4. For plain warts, HPV 3 and 10. And take note of the epidermodysplasia verruciformis. So these are rare autosomal recessive inherited skin disorder that confers increased susceptibility to certain types of HPV. And what is important is that this carries a higher risk for malignant transformation and 30 to 50% risk of squamous cell carcinoma, especially types 5 and 8 HPV. Now moving on to the mucosal type, this includes condylomata cuminata genital or venereal warts. These warts have risk for malignant transformation. Notable are the HPV type 6, 11, 16, 18, and 31, for which the 6 and 11 confers low risk for malignant transformation, and the remaining, the type 16, 18, and 31, and even 33, they are conferring high risk for malignant transformation. So the treatment for these warts for children, usually no treatment because spontaneous regression is common. However, if there is persistence of the lesions, and most especially for adults, cryotherapy using liquid nitrogen, salicylic acid, silver nitrite, butyraldehyde, electrodesiccation, cryoablation, pulsed dye laser therapy, H2 antagonists, and zinc sulfate are acceptable treatments. For the next case, this is a case of a 2-month-old girl brought by her mother for consult for a rapidly enlarging bright red lesion on her right cheek. It first appeared when she was still 1 week old. During that time, they were reassured by her pediatrician that it was just a benign lesion that would involute later in life. No other congenital anomalies noted. Except for the visible lesion, the girl appeared well with no other symptoms. What would be the best advice for this patient? This is a case of proliferating infantile hemangioma, for which surgery is actually not the first line of treatment. It's actually propranolol. Propranolol is a beta blocker causing cessation of growth and regression of the lesions. It's usually started between 5 weeks to 5 months age in oral form. So, hemangioma are actually benign vascular tumors arising from the proliferation of endothelial cells that surround blood-filled cavities. The presentation is usually shortly after birth, not during birth. So that's an important delineation. And there is noted a period of rapid growth, specifically during the first year, and then followed by gradual involution over childhood in more than 90% of the cases. So this is the reason why we don't offer surgery upfront for these cases, because these lesions are usually expected to involute when the child is growing older. However, in some rare instances, if the tumor persists into adolescence, leaving a cosmetically undesirable defect, surgical resection will now be considered. And also, should remember that these hemangioma can also be part of a syndrome. One example is a congenital face syndrome. Also, even though I mentioned that we usually wait for the involution of these lesions and not offer surgery upfront, there are situations in which surgical resection is indicated prior to involution, and the most common indication is that when these lesions are obstructing the airway, obstructing the GI tract. So when they are causing physiologic difficulties for the patient, this is an indication to remove these lesions. Second is, if the hemangioma is too large, it can often cause high output cardiac failure and consumptive coagulopathy. Also, when these lesions grow in big sizes, it can cause cosmetically undesirable defect after involution. And if these lesions are causing life-threatening and affecting overall function of the patient, these lesions are removed regardless of age. One important differential diagnosis for hemangioma is the vascular malformation. On the screen is a table showing the difference between a hemangioma and a vascular malformation. So in the case of hemangioma, these are usually true tumors and true benign neoplasm. For vascular malformation, there is actually no tumor. It's actually a group of tortuous vessels that appear like they are tumor. Hemangioma is also more common in females with a 3:1 ratio, while vascular malformation, there is no gender predilection. Hemangioma can appear small or absent at birth and then appear later, after a few days or a few weeks. And then that makes it different from vascular malformation in which these lesions are already present at birth. And also the rate of growth for hemangioma is rapidly growing during infancy, while vascular malformation, the growth of the tumor, quote-unquote tumor, which is not actually a tumor, they're just tortuous blood vessels, they are growing proportional to the child's growth. And lastly, hemangioma are expected to involute and are self-limited. On the other side, the vascular malformation, it will not involute and will not disappear. With regards to nevus or nevi, when should a mole be removed? So the absolute indication of which moles, especially in children, are removed is that when these moles are actually giant congenital nevi. The reason behind it is that up to 5 to 8% it can develop into malignant melanoma. Giant congenital nevi is characterized by moles that are about 20 cm big. Therefore, since these lesions have malignant potential, they can be excised as early as it is feasible. On the screen are a list of the most common cysts that we encounter. So the first one is the epidermoid cyst, which is actually the most common cutaneous cyst. They are characterized by keratin plug parasebaceous units with granular layer, and they appear as singular keratin plug punctum. Next one is a tricholemal cyst. From the word itself, you can see that it's really found in hair follicles. What separates it from epidermoid cyst is that it lacks the granular layer. Again, it is found in the scalp or hairy areas in the body. The third one is the dermoid cyst. It consists of persistent epithelium with embryonic lines of fusion. And the most frequent site is the eyebrows, and the treatment of choice is complete surgical excision. With regards to keratosis, a very important lesion that we need to look out for is the actinic keratosis. These are actually neoplasm of the epidermal keratinocytes. However, this is a common pre-malignant lesion for squamous cell carcinoma. It is believed that 60 to 65% of SCCA originate from actinic keratosis. These are usually seen in fairly skinned elderly individuals in sun-exposed areas for which UV radiation poses the greatest risk factor. The treatment includes excision, use of fluorouracil, cautery and destruction, and dermabrasion. The next one is seborrheic keratosis, which is described as well-demarcated stalk-on appearing papules or plaques. They are also seen in elderly individuals, and the difference between this and the actinic keratosis is that it has no malignant potential. For the neural tumors, we have the neuroma, schwannoma, and the neurofibromas. For the neuromas, these are actually disordered growth of Schwann cells and nerve axons. And these are usually seen in sites of previous trauma or along the scar lines. And these are usually painful lesions. On the other hand, schwannoma or benign proliferation of Schwann cells of the peripheral nerve sheath. And what sets it apart from a neuroma is that this one has no axons. Schwannomas are related to NF type 2. And in contrast to neurofibromas, which is related to NF type 1. So we'll go to that later. The schwannoma can cause pain, not because the lesion is painful, but because these tumors can actually displace the nerves surrounding it. So that displacement causes the pain. Next is the neurofibromas, which is characterized by benign proliferation that make up all nerve elements. Again, they are related to NF type 1 with cafe au lait spots and leash nodules. The indication for excision is the recent development of pain from a previously asymptomatic lesion. Because the presence of pain in a previously asymptomatic lesion can be a sign and symptom of malignant transformation. So we have finished running down the non-cancerous tumors. We now proceed to the malignant tumors. This is a case of a 62-year-old male pilot who consulted for a 2-month history of mass located near the tip of his nose. He initially went to a dermatologist for which a punch biopsy was done, revealing tightly packed cells palisading in the periphery, hence the referral for surgery. On physical exam, the lesion appeared as a 1.5 mm pearly pink nodule with arborizing and branching vessels. Which of the following is the best management for this case? This is actually a case of basal cell carcinoma characterized by pearly pink nodules and branching vessels. At the picture, you can see that the lesion is located at the tip of the nose, which is considered as a cosmetically sensitive area. For these specific tumors, we can actually offer the patient most micrographic surgery with reconstruction. For a short description of basal cell carcinoma, this is actually the most common skin cancer. The primary risk factor is sun exposure, with UVB being a greater risk factor compared to a UVA. It is caused by mutation of tumor suppressor gene p53 in 50% of the cases. And for basal cell carcinoma, melatonin is actually protective. Hence, the more light-colored skinned individuals are more predisposed to BCC compared to dark-skinned individuals. Also, the rate of distant metastasis is rare. The required margin for BCC is actually 4 mm, specifically in cosmetically sensitive areas. And in other areas such as the arms, trunk, we can increase this margin to 10 mm. In relation to the required margin, if we do most micrographic surgery, we can actually decrease further the required margin to 2 mm and still give an oncologically acceptable result. For the variants of BCC, we have actually 4 variants. The nodular, which is the most common. It is characterized by raised pearly papules with telangiectasias, which are the branching vessels. And it usually has a depressed tumor center with raised borders. It is called rodent ulcer appearance. These nodular BCC are low risk. The next variant is the superficial spreading. These are usually confined to the dermis, appears as flat pink scaling or crusting lesions, appearing in the trunk and extremities. These are also low-risk lesions. For the high-risk lesions, we have 2. The first one is infiltrative, in which we usually see these lesions on the head and neck along the embryonic fusion lines, among the elderlies on the late 60s. They appear like opaque yellow-white color with no raised edges. The morphiiform is the most aggressive subtype, according to Schwartz, and it appears like an enlarging scar with indistinct margins, or high risk. In some books, they are already showing that the infiltrative type is the most aggressive subtype, but for the purpose of our exam, we will stick with morphiiform as the most aggressive subtype. So the most common location of BCC is the sun-exposed area of the nose. And when you see a BCC on the lips, it's usually affecting the upper lip. For contrast, if the lesion is seen in the lower lip, it's usually an SCCA instead of a BCC. BCC can also be found in the eyelids. One common syndrome linked to BCC is the Gorlin syndrome. It is also called the basal cell nevus syndrome. And you have to take note that when you have Gorlin syndrome, RT is contraindicated. What is Mohs microsurgical excision? It usually involves sequential horizontal excision of the sectioned specimen. Usually in the conventional frozen section, you don't section the specimen in a horizontal manner. You usually section the specimen like a bread loaf, so vertical, pa ganon. But in Mohs, you section it like this. And then you label the margin edges, 12 o'clock, 3 o'clock, 6 o'clock, and then 9 o'clock. So that for each cut of this specimen that you do frozen section on, when an edge comes out positive, you know exactly where on the tumor bed that positive margin is, so that when you need to re-excise, you don't need to re-excise the entire thing. For example, you section this specimen and then you see a residual tumor at the area of a 3 o'clock position on cut 3. Okay, so you just take this specimen, and then instead of re-excising the entire thing, you can just get a small portion of 3 o'clock and then send it again to the histopath. That way, it is more cost-effective and it is associated with lower recurrence, and then your margin doesn't have to be too big. This is a treatment of choice for morphiiform or other BCCs with aggressive features, and those BCCs with poor delineated margins and recurrent tumors. This table is lifted from NCCN, which shows the low risk and high risk features for BCC. So again, if you have low risk BCC, you can just do away with a 4 millimeter excision margin. And if you have a high risk BCC, it's advisable that you offer this patient Mohs micrographic surgery. For low risk BCC, again, you can do excision with 4 millimeter margins with post-op margin assessment by frozen section. And then, if after excising your margins turn out to be positive, you can now do Mohs. But you also have an option to go straight to Mohs if you don't want to do this 4 millimeter margin first. So going straight to Mohs is fine. For high-risk lesions, the best answer is always to do Mohs. If Mohs is not in the choices, you can do wide excision with wider margins. So when you say wider margins, it's not 4 millimeter margins. NCCN on its footnote, it's written that due to the wide variability of the clinical characteristics that may define a high-risk tumor, it's not feasible to recommend a defined margin. So they didn't really say what margin is needed for a high-risk tumor. So basically, it's just anything that is more than 4 millimeter. If the margins stay persistently positive despite re-excision, you can do adjuvant radiotherapy. But take note again that if this patient has Gorlin syndrome, you cannot do radiotherapy. And then systemic therapy can also be done for very, very high-risk patients in the form of vismodegib. It is given when surgery and curative RT are not feasible or if the lesion is persistently positive and high risk. Okay, next case. This is a 45-year-old male with history of previous second-degree burn from an industrial accident at the left popliteal fossa region, who came in due to rapidly growing, non-healing 3 cm ulcer about 6 mm deep along the site of his previous burn wound. There is also palpable mass at the left inguinal area, which was later confirmed by a CT scan. Core needle biopsy of the inguinal mass was positive for metastatic squamous cell carcinoma. Other lesions noted. There are no other lesions noted on the pelvic, abdominal, and the chest CT scan. So what is the most appropriate management for this patient? This could be a case of a marginal ulcer, which is an SCC that arises from an area of chronic wound or burn scar. So the appropriate management for this patient is actually wide excision, including the subcutaneous fat, frozen section to check the appropriateness of the margins, which is 6 millimeters, with regional lymph node dissection at the left inguinal area, followed by reconstruction and radiotherapy. Squamous cell carcinoma is actually the second most common skin cancer. The primary risk factor is UV radiation exposure. Indicators for worse prognosis is a lesion more than 2 cm. So in our patient, it's a lesion it's about 3 cm. The depth of invasion exceeds 4 millimeter. And there is history of rapid growth, and it's located on the ears, lips, nose, scalp, or genitals, and has positive lymph nodes. The resection margin recommended are as follows. For low-risk lesions, we recommend 4 millimeter margin, and for high-risk lesions, we recommend at least 6 millimeter margin. There are actually some in situ variants of SCCA, notable of which are the actinic keratosis, which is the most common, the Bowen's disease, which is described as full-thickness epidermal dysplasia, characterized as scaly erythematous patch, often with pigmentation and fissuring. And if this occurs in the glans penis, it's called the erythroplasia of Kierat. 10% of these cases will eventually become invasive. Other things to know are de novo invasive SCC, which are usually seen in organ transplant and immunocompromised patients with metastasis rate as high as 14%. Marginal ulcers, as described earlier, and the keratoacanthoma, which is described as rapidly growing nodules with a central keratin plug. For patients who present with clinically palpable regional lymph node, and when they are proven to be metastatic after a core needle or an FNAB, we proceed to doing a wide excision with 6 millimeter margin. 6 millimeter because it's a high-risk lesion. And then proceed to a regional lymph node dissection on the ipsilateral side, followed by RT, if high risk. For the RT, we can also combine the RT with a sensitizing chemo in the form, if this is squamous cell, it is in the form of platinum-based agents such as cisplatin. Other scenarios for SCCA. So when do we do MOS? We do MOS if the margins after excision is persistently positive. We can do MOS for recurrent tumors in areas where cosmesis or functional preservation is critical, for poorly differentiated tumors or high-risk lesions, for invasive lesions and verrucous tumors. And then for regional lymphadenopathy, we do regional lymphadenopathy if we have tested by FNAB or core needle biopsy the lymph nodes and they come out positive. And also, we can do regional lymphadenopathy when these lymph nodes are positive on cross-sectional imaging. And then for sentinel lymph node, yes, we do sentinel lymph node for SCCA. We do it for high-risk cases wherein there is clinically node-negative disease. The method is practically the same as a melanoma, wherein we use a technetium-99, which we inject peritumorally or around the resection scar. And then immediately before surgery, we use a gamma probe to verify the position of the sentinel node, and then inject patent blue dye intradermally. For patients with parotid disease, since the parotid gland is located on the head, it is considered as a high-risk lesion. So for these patients, we do superficial or total parotidectomy with facial nerve preservation plus ipsilateral neck dissection if node positive, and then followed by adjuvant radiotherapy. And RT is done in patients that are poor surgical candidates. We do adjuvant therapy for large high-risk tumors with cure rates approaching 90% because squamous cell carcinoma are basically very radiosensitive. This table shows again a summary showing low risk, high risk, and very high risk SCC and their management. Again, for low risk, the excision margin is 4 millimeters. For high risk, we do Mohs or excision margin of 6 millimeters. And for very high risk, we do Mohs with lymph node dissection followed by RT with or without systemic therapy. The next case is a 40-year-old surfer from Siargao consulted for a mole on the back that recently changed in appearance and size. On PE, the mole measures 7 mm in diameter, had an asymmetric appearance, and with combined light and dark brown patches. He also recalled one episode of bleeding a week prior which spontaneously resolved. Aside from this mole that is evolving, his back has numerous other adjacent moles. He narrated that he used to live in Cagayan and was member of the swimming team back in high school. Full thickness sponge biopsy with margin of normal skin was done confirming melanoma with 3 mm thickness, dermal mitotic rate of 2 per millimeter squared, and positive for microsatellitosis. There are no clinically palpable lymph nodes. His PET CT scan was negative for any metastatic spread. So what is the appropriate next step for the management of this patient? Melanoma is the most aggressive skin cancer. It is due to the propensity for distant metastasis. The median lifespan for melanoma patients is about 6 to 8 months after diagnosis. They usually arise from the melanocytes at the epidermal-dermal junction, and the most important risk factor is exposure to UV radiation. The other risk factors include childhood sunburns, residence at high altitudes or close proximity to the equator, presence of dysplastic nevi, familial atypical multiple mole melanoma syndrome, and giant congenital nevi. These is the list of many genetic mutations that melanoma patients has. Pertinent to this is the p53 tumor suppressor gene. And the behavior of this melanoma is that initially it acts as a localized radial growth phase followed by a more aggressive vertical growth phase. So when we talk about melanoma, we often mention the ABCDE of melanoma, which is the asymmetric. They have irregular borders. They have color variations. The diameter is usually greater than 6 mm, and they undergo evolution or change. There are different types of melanoma. The most common type is a superficial spreading, which comprises 50 to 70% of the cases. These superficial spreading melanoma arises from the precursor melanocinic nevus. Then we have the nodular melanoma, which arises de novo and more common in men, located at the trunk. This is the most aggressive type of melanoma because it exhibits an early vertical growth pattern and is often diagnosed at a later stage. The third type of melanoma is the lentigo maligna. So even though the word has the word maligna in it, it is actually the less aggressive type. And it usually arises on sun-exposed areas of the head of the trunk and head and the neck, And then we also have the acrolentigenous melanoma. What is pertinent about this is that this is the only type of melanoma that is not due to sun exposure. In the diagnosis and staging of melanoma, it is very important that you examine the entire skin of the patient. You look for synchronous primaries, you look for satellite lesions and intrinsic metastases. And also, if you plan to do a lymphadenopathy on this patient, all nodal bases should be examined for it. And when you have suspicious lesions, these should be biopsied with a 1 to 3 millimeter margin. However, you should take note that you should not over-excise these lesions, especially if you're not going to do the lymphadenopathy yet. Because when you over-excise these lesions, it will affect the accuracy of your sentinel lymph node biopsy should you need it. And then all suspicious lymph nodes should undergo an FNAV or core needle biopsy. When we talk about melanoma, one very important aspect is the determination of the breast lobe thickness. So what is the breast lobe thickness? The breast lobe tumor thickness has already replaced the old Clark's level for determination of prognosis among melanoma patients. So it used to be that the Clark's classification or levels, which comprises of 5 levels, it's actually defines what layer of the skin the tumor has reached. For breast lobe thickness, however, it is described in millimeters. And in every millimeter that you have for breast lobe thickness, it actually tells you the prognosis of the patient in the form of the 5-year survival. And then also the breast lobe thickness will also suggest or define to you how many centimeters of margin peripherally you need to be able to excise this tumor completely. So if you have a breast lobe thickness of less than 1 millimeter, you need at least a 1 cm margin. So if it is a 1 to 2 millimeter thickness, you need 1 to 2 cm of margin. And if you have a 2 to 4 millimeter breast lobe thickness, it will require you to have 2 centimeter margins. And anything above 4 millimeters, also 2 centimeter margins. One of the most common questions that are asked when it comes to melanoma is this question: what is the most important prognostic indicator in melanoma? Actually, the answer to this question depends on the case. If the question is just given to you as it is, what is the most important prognostic indicator in melanoma, the answer will be breast lobe thickness. But if the question will tell you that the melanoma has regional node metastasis, your answer is not anymore breast lobe thickness. The answer becomes the number of nodes affected. If the question will tell you that what is the most important prognostic indicator in melanoma among patients that has metastatic or stage 4 disease, your answer will be the site of metastasis and elevated LDH levels, not anymore the number of nodes and not anymore the breast lobe thickness. So again, to answer this question, it really depends on the case. So the only time that we do not do SLNB in cases of melanoma is that if the patient's risk for positive sentinel lymph node is less than 5%. This is usually seen in patients with stage 1A T1A melanoma with a breast lobe depth of less than 0.8 millimeters. So anything that is more than 0.8 millimeters and any melanoma that is more than stage 1A or anything that is stage 1B and above, they should always have an SLNB, especially if they have high-risk features. An exception to the rule to this is that if you think that you don't have an adequate specimen, and if you don't have adequate specimen, your staging is now uncertain. So if you have any uncertainty with your pre-op staging, you can do sentinel lymph node biopsy. As I have said, SLNB is indicated in melanoma for stage 1B, T1B, and above. You should always do SLNB also in lesions that are ulcerated. So even though the lesion is small, but you see that there's an ulceration, you need to do an SLNB. You have to remember that melanoma is a very aggressive skin cancer. In doing melanoma surgery, we do preoperative lymphatic mapping. This is basically like a sentinel lymph node lymphoscintigraphy that we do in the breast. So what we do is we send this patient to nuclear medicine and have the patient injected with radiocolloid tracer, the technetium-99, and then we also inject intradermally in 4 to 5 locations around the biopsy site a blue dye. And then the purpose of this is to identify the nodal basins that should be mapped according to the location of the lesion. So for our patient, since the lesion is at the back, we are expecting that the sentinel lymph nodes can be found. It can be found in the axillary area. It can be found at the subscapular area. So those are the probable areas wherein we will find the sentinel lymph nodes. You have to take note that when we do lymphatic mapping, we should do it first before the wide excision. This is to allow proper dispersal of the radiocolloid tracer for us to be able to properly identify the sentinel lymph nodes. Also, we have to inject the blue dye intradermally and not subcutaneously for obvious reasons, because the melanoma is in the dermis. And if you inject it on the subcu, it will not go there to the lesion. Also, the location of the incision, we determine it through the putting the gamma probe, and we put it over the site of the highest transcutaneous count. So that's the location of the incision. And then to be able to know if our dissection is already enough, we check the gamma count on the surgical field. And if it is still recording measurement above the 10% of the threshold, then further exploration still needs to be done. You also have to know that there is the presence of in-transit sentinel lymph nodes, and if the sentinel lymph nodes in transit are found more proximal to the draining nodal basin, these in-transit sentinel lymph nodes should be excised. And in cases wherein the patients have also positive iliac nodes, if these iliac nodes are sure that they are connected to the more superficial nodes, you don't need to remove them. However, if there is doubt and you think that the nodal drainage is different, you need to excise them separately. The presence of microsatellitosis represents microscopically identified lymphatic metastasis. So lymphatic metastasis is a sign of poor prognosis. So if this is present in your patient, it actually upstages the tumor to an N1, N2, or N3 tumor. So it upstages the cancer to at least a stage 3. This is just a list of immunohistostains that are often used in the diagnosis of melanoma. The most sensitive marker to visualize invasive melanoma is actually the S100. So what is the role of most micrographic surgery in melanoma? Unlike in the basal cell and squamous cell CA, most is not recommended for primary treatment of invasive cutaneous melanoma, simply because we really need the standard clinical margins. We can just consider the most probably for minimally invasive T1A melanomas, but for other stages of melanoma, we cannot really properly stage a melanoma with just most micrographic surgery. You actually need to wait for the permanent sections to be able to complete the staging. And what disadvantage of this is that if you choose to do most micrographic surgery during the first surgery, you actually have to delay reconstruction because you cannot reconstruct until the final result is out. For diseases not amenable to complete excision, we can also do isolated limb infusion. This is basically giving chemotherapy in high doses, and the most common agent is the mephalan. And this is to avoid systemic drug toxicity while giving chemotherapy to the limb. So basically, they put a tourniquet on the limb, put IV cannulas, and then infuse chemotherapy, and that chemotherapy will actually just circulate on the affected area and not go to the general circulation. Other questions that may be asked regarding melanoma: the most common sites of metastasis, the lungs and the liver. What other things that we can give? We can give BRAF inhibitors such as sorafenib. We can do anti-PD-1 antibodies, CTLA antibodies like ipilimumab, and high-dose interleukin-2. The most common site of non-cutaneous melanoma is the ocular melanoma. Other malignant lesions that can be asked in the exam is the Merkel cell carcinoma. It is an aggressive neuroendocrine tumor of the skin, which is cytokeratin 20 positive. For this, the recommended excision margin is around 1 to 3 centimeters, and you have to do sentinel lymph node biopsy prior to wide local excision, completion lymphadenectomy, and radiation therapy. For Kaposi sarcoma, again, this is related to the human herpes virus 8, for which you see a multifocal rubbery blue-red nodules, and the treatment of choice is antiviral therapy. Another is the dermatofibrosarcoma protuberans. It is a rare low-grade sarcoma of fibroblast origin. It has low distant metastatic potential, but it behaves aggressively locally with finger-like extensions. It is CD34 positive, and the treatment is wide local excision with 3 centimeter margins. We can also do Mohs microsurgery, especially for cosmetically sensitive areas. Another lesion is the malignant fibrous histiocytoma, or the undifferentiated pleomorphic sarcoma and myxofibrosarcoma. It is basically spindle cell cutaneous soft tissue sarcoma occurring in the extremities, head, and the neck of the elderly patients. And 50% of these patients, this is already my last slide. So for the last two tumors, we have the angiosarcoma, which arises from the vascular endothelial cells. It has poor prognosis, and it looks like an ill-defined red patch on the face or scalp, often with satellite lesions and distant metastasis. It is associated with lymphedema-associated angiosarcoma, otherwise known as Stewart-Trevis, and it develops in the extremity ipsilateral to a previous axillary lymphadenopathy. So this is treated with surgical excision with wide margins. And last but not least is the extramammary patch disease, which is basically an adenocarcinoma of the apocrine glands. And what is important with extramammary Paget's disease is that if you have this, there is very high likelihood that you have another malignancy going on. So you have to investigate where that other malignancy is coming from. Usually it's coming from the gastrointestinal or the genitourinary system. And the treatment is surgical resection with negative microscopic margins and adjuvant radiation. So that concludes